Hello? Okay. Good morning, everybody. As Pacific Islanders, we always open with prayer. Okay, some of you don't go to church, huh? But, in like the traditional Pacific Islander fashion, we definitely open with prayer, and we have the pleasure of having Reverend George here to open us today with the prayer. So please welcome Reverend George.
May I have everybody to stand up, please? I'm not going to tell you to stretch, but I'm just asking you to stand up. I'm going to pray in God's language, which is Marshall Islands. So, I know, yeah, good. He knows Marshallese so well. Kami kamolo lagani jele chupunin riyolagin John Ranaman, trainin kin karo, komolagan kobadogin loroto jin chongo jim John. Kami kajile ke pembon kajaraman oleven program kinam rainin mai yana ni chamalak ilo rainin ina the nijam cheese komolat. Amen. See, he knows. Oh, I'm sorry.
Thank you, Reverend George, especially in sharing God's language. But he was born in Samoa. Okay, before we start, we have the pleasure of having a speaker here with us today. And actually, I'm going to have the executive director of APCHO come up to present our first speaker. And please welcome Jeff Caballero from APCHO.
Good morning, everybody. Gotta excuse me, I just ran here from the hotel. Nia goes, "You're up now." Good morning again. As Tana said, my name is Jeff Caballero, and I'm the executive director of the Association of Asian Pacific Community Health Organizations, or APCHO for short. As a national advocacy association for Asian Americans, Native Hawaiians, and Pacific Islanders, we've been working for over 30 years, and it is for that reason that it is an honor for me. Thank you, JoAnn. For that reason, it's an honor for me to be able to introduce to you a very special guest from the Office of Minority Health. The Office of Minority Health has been a very important partner for our minority communities and our communities of color for over 30 years. It's perhaps the closest federal office partner that I could say that our community has had over the last 30 years. And for those of you who don't know, the Office of Minority Health is dedicated to improving the health of racial and ethnic populations through the development of health policies and programs that will help eliminate health disparities, provide access to quality care, and advance health equity. Excuse me. It is my privilege to introduce to you Dr. Matthew Lin, the newest Deputy Assistant Secretary for Minority Health at the U.S. Department of Health and Human Services. This is actually the first time I'm meeting him as well. It's just like many of you. It was really generous of Dr. Lin and the Office of Minority Health to accept this invitation. In fact, we received the press release on August 21st about his appointment, and that very next day, Nia had a planning call for this meeting committee, and I said, "Hey, Dr. Lin just got appointment. Would you like to invite him to speak to our conference?" And they were so quick in responding to us. And I just wanted to share with you that they were probably very excited to meet you and get to know you and your community. Dr. Lin received his medical degree from Taipei Medical University. He arrived in the U.S. from Taipei in the early 1970s. He completed his residency at Baltimore at MedStar Union Memorial Hospital and Johns Hopkins University, where he specialized in hand and orthopedic surgery. Dr. Lin has spent most of his professional career serving a primarily minority population in the San Gabriel Valley of California. Among other responsibilities there, he served as a member of the board of directors at Alhambra Hospital and Garfield Medical Center. He has also served as a mayor, a vice mayor, and city councilman in San Marino, California. However, I'm sure most of you would be interested too, that this man has not only served in Baltimore and Southern California, where for many of us, we can say life is very comfortable. Dr. Lin has also provided medical relief efforts for natural disasters worldwide, including the 2015 earthquake in Nepal. He was there at the 2010 earthquake in Haiti, the 2005 tsunami in Sri Lanka, and Hurricane Katrina in New Orleans. Ladies and gentlemen, please share an aloha welcome to Dr. Matthew Lin. Wherever you prefer. You're very welcome. Thank you.
Thank you, Jeff. Aloha, everyone. This is Dr. Matthew Lin. Whatever he said, I almost forgot all of them, what I did. But it is great to be here with all of you today for the 2017 Gathering for Pacific Islander Health. Jeff mentioned earlier, I am one of the Pacific Islander. I come from Taiwan about 43 years ago. So I hope I could see what you see. I could feel what you feel. I just got appointed as a Deputy Assistant Secretary in the U.S. Department of Health and Human Service. I get my dream job to be in charge of minority health. This is what I want to do. I do some study, and now there's a lot of opportunity for us to improve the health in the Pacific Islander area and Hawaii Native. First of all, I want to thank the Center for Pacific Islander Health at the University of Arkansas for Medical Science for inviting me to join you. And I want to thank all of you for the great work that you are doing it. I was very happy to learn that goal of this organization is to build a community of researcher and practitioner to reduce health disparity here in the Pacific Islands. I want to begin by telling you some of myself, Jeff mentioned it earlier. Some of them I forgot, but some of them not. I'm also a big surgeon, practiced in the area, Southern California, for the last 40 years, until I retired 2 years ago. I serve primarily all of minority community in the San Gabriel Valley. I went to do some medical mission, but I do bring my children to go with me to Africa 5 times and to Haiti and to different areas. In August, I was appointed as a Assistant Secretary in the United States of Department of Health and Human Service, in charge of minority health. This is really my dream job. My dream is get everyone in this world have an equal right for the best possible opportunity for their health. I cannot describe how proud I am of having this opportunity to serve. I have dedicated much of my life working to make sure that everyone has the best possible chance to reach their full potential for health. Because I think this is one of the most important things that we can do for the people for the health of the people and for the world. We have made great progress over the years, but of course, there is a lot of work yet to be done, especially for the Pacific Islanders. That fact that can be seen in the disparities that Asian American, Native Hawaiians, and Pacific Islanders facing. What they're facing, Native Hawaiian men have highest mortality rate for all type of cancer compared with any other ethnic group in the United States. Why their mortality rate is high? I think probably their cancer was detected late. Native Hawaiian and Pacific Islander adolescents are about 50% more likely to be overweight compared with white adolescents. Their overweight make them become some more health problem like diabetes, coronary artery disease, and everything else. High percentage of Hawaiian, Native Hawaiian, Pacific Islander in the United States have diabetes. We have 15%, 15.6%, compared with other single Asian adult 8%, or U.S. adult 8.7%. We are twice as much who have diabetes. Asian Americans are 8 times more likely to die from the hepatitis C compared with white. Why hepatitis C causes so high mortality? Because it was diagnosed late. 50% of the Asian American or Pacific Islander do not know they have a disease. Again, for the hepatitis B virus, Asian American and the Pacific Islander represent 50% of the population in U.S. who have the hepatitis B, compared with our population is only 5% of U.S. population. Actually, if you do the survey, probably 1 in 10 of the Pacific Islander and Asian American, 1 in 10 have hepatitis B that carrier that they don't even know it. We did not really do enough for those diseases. The Native Hawaiian Pacific Islander have higher rate of smoking, alcohol and drug abuse, and obesity than other ethnic groups. Smoking is a problem for our health. And as we highlight effort to improve the health and health care for Asian American, Native Hawaiian, and the Pacific Islander, I'm proud to tell you that my Office of Minority Health has spent the last 30 years raising the health issue of diverse population, especially to the Pacific Islander and Hawaii Native. I'm pretty sure that you know that our Office of the Minority Health came because of the 1985, the report we call the Heckler Report, is one of our former secretary, Heckler, make the report to the Congress. Everything that we do through health policy and the program is designed to reduce the health disparity and improve the health of race and ethnic minority population. That is our mission, and our strategic priority are aligned with our mission. Number one, we will support initiative and the program that provide access to the quality health care. Number two, we are leading the implementation of the HHS action plan to reduce racial and ethnic health disparity. And number three, we will coordinate with the National Partnership for Action to end the health disparity and the national stakeholder strategies for achieving health equity. These are our priority. Office of Minority Health also has a number of other focus areas that raise the level of strategic priority as well. For example, number one, response to the public health crisis. We've been sending a lot of staff to the Puerto Rico and to the Texas, and also the Flint, Michigan water crisis and the Zika virus. Number two, behavioral health is another focus for us. Do you know what is number one reason of deaths in the age between 12 to 16 in the Indian Reservation area? Not the infection, not the disease, it's suicide. So mental health, it becomes a very serious issue that sometimes we overlook. Our work is also guided by the priority of a new administration right now, with three top priorities. Number one is opioid abuse. Opioid abuse costs the United States every day 95 people die from opioid abuse. Number two, childhood obesity. We want to have a healthy American year 2030. Childhood obesity need to be eliminated. Number three, serious mental illness is reflected in the United States. I'm sorry to see that the shooting in Las Vegas, and a lot of those incidents may have something to do with a serious mental illness. So during the course of this meeting, as you're beginning to identify how we can help your organization achieve health equity goal, it will be important for you to think about our Office of Minority Health mission and strategic priority, as well as our Department of Health and Human Service priority. We consider you as a partner with us to work to reduce the health disparity and advance health equity. It is very important. I know yesterday when I have a meeting with some of your friends, we're talking about the workforce. And we've been working very hard, trying to see if we could create a pipeline to have more healthcare provider or professional to go through the pipeline to serve our community. But I point out another interesting fact. In Hawaii, we have 9,000 physicians registered as a licensed physician in Hawaii, but only about 3,200 are practiced in Hawaii. Where is the other 5,000 physicians go? And I told them that probably we need to look into it. Maybe they are in the golf course too often. We need to bring them back. Yeah. Okay. Now, Office of Minority Health have a long history of helping healthcare professionals and organizations achieve their goal. For example, of our target for the Asian Pacific Native Hawaii Pacific Islander population, we did a few. For many years, we provide support for the active of the Office of Pacific Health. Pacific Health is one of our support in Hawaii. Number two, OMH National Workforce Diversity Pipeline Program have provided grant to a number of institutions in the region. Right now, for example, we funded a program to build a healthcare workforce program at the University of Hawaii Medical School. Number three, OMH working in collaboration with the National Center for Health Statistics to develop the Native Hawaii and Pacific Islander Health Interview Survey. This survey was released earlier this year. It is first federal survey designed exclusive to measure the health of Native Hawaii and Pacific Islander population in the United States. And this survey report is available in our resource, OMH, the Resource Center. This survey has already helped users to highlight the difference in health condition between the Native Hawaii and the Pacific Islander population and the Asian population, whom they have historically been combined together. I think the need is different and the disease is somewhat different. So we like to segregate it out so we could see what we can do better for the Pacific Islander and Native Hawaii. OMH also provides support for the work by the National Academic Science Study to develop a nation strategy for the examination of hepatitis B virus and hepatitis C virus. Final report released in March include a set of recommendations and goals for eliminating hepatitis B virus and hepatitis C virus disease and the mortality as a public health threat. Hopefully, we could eliminate by year 2030, but I really hope we can eliminate hepatitis B and C much earlier. Our Pacific Islander and Native Hawaiian have much higher mortality rate in hepatitis C than others. So I have just touched surface of the opportunity that may exist for us to help you. In closing, I would like to urge you, if you have already done so, to visit our website. Our website is minorityhealthhhs.gov, where you find a variety of resources, particularly information about funding opportunity announcement. And our office will help you to go through to fund the funding opportunity and to help you write the grant and everything else. Some of you may know Henry O'Campos. Henry is in the San Francisco office, an employee of the Resource Center. His number is 888-444-6472. Call him anytime if you need something, including money. And again, thank you for inviting me. I'm looking forward to meeting as many as you as possible. I'm here, and I'd like to recognize my staff, Dr. Sammy Wu. Would you mind to stand up to be recognized? And I'm on the job for 1 month. Sam in the job is much longer, so anytime you ask me any question, ask him first. And again, thank you for your listening. I appreciate for the opportunity. Thank you.
Another round of applause for Dr. Lin, our new OMH director. We thank you very much. We look forward to supporting you in your leadership. Okay, who was here yesterday? Raise your hands. All right, who's here for the first time? Raise it nice and high, first time. Okay, well, I'm gonna do an introduction, Talofa. My name is Brad Pitt, but you can call me Tana. I had an audition yesterday to do some presentation, and Nia welcomed me back just 5 minutes ago to do today's panel. So, you know, with Nia, the Queen of the Pacific, our to-do list has to be on a dry erase board, right? Because it's constantly adjusting, right? So, it's an honor, though. Today's panel, or plenary session 3, is titled, I'm a newcomer to glasses, folks, so please excuse me as I transition. It's titled Bridging the Gap Through Education and Training. And we have 2 wonderful presenters today. What I'm going to do is read the bio, have them present, and if we could please hold the questions for the end, that'd make it hopefully a smooth transition for all of us. So our first presenter is Dr. Billy Thomas. He is the Vice Chancellor of Diversity and Inclusion at the Center of Diversity Affairs at the University of Arkansas for Medical Sciences. Dr. Thomas is also a professor in the Department of Pediatrics and associate professor at the College of Public Health at UAMS. Dr. Thomas is a board-certified pediatrics and perinatal medicine. He graduated from Arkansas State University and received his MD degree from the University of Arkansas for Medical Sciences. In 1986, he completed a fellowship in neonatal medicine at Case Western Reserve and joined the faculty as an attending neonatologist at Arkansas Children's Hospital in Little Rock, Arkansas. In 2004, he received his master's degree in public health from the Tulane School of Public Health. Ladies and gentlemen, please welcome Dr. Thomas.
Show me how to work this thing here.
Okay. Let's see.
Aloha. I've been waiting to say that all morning, you know.
And then either up or down, if you want the mouse.
Okay.
Up or down.
You know, I was just sitting there thinking and listening to Dr. Lin. You know, my learning curve is very, very steep. especially, as far as cultural and ethnic. I guess just learning about Marshallese and Native Hawaiian, but and listening to him talk, we're really on the same page. I think we're all here because we look at health equity, and health disparities, and that's really what this is all about. So, again, my learning curve is very steep, but I think we're trying to do the right thing, and that's really why I'm here. Now, Nia asked us to come. There's Kim Bland is here also from UAMS, and she wanted us to talk about workforce development. And so that's kind of what the talk will be about. I really do appreciate the time, and it's really an honor to come and talk to you all, because I think, what we're trying to do is really to look at marginalized populations. And we're trying to help those marginalized populations become part of the game, so to speak, to become included in the game. And Dr. Lin kind of alluded to it. The bulk of what we do is pipeline programs. But beyond those pipeline programs, there are other things that we do that are for the greater good, so to speak. And that includes faculty development, community associations, and so on. So I'll go through these slides, and again, I'll show you some pictures also of some students and programs that we had this past summer. And pictures sometimes speak louder than words, so I would like to do that. So I'll get started. And this first slide just kind of says who I am, and that's the title of the talk here. And this is like a vision statement for UAMS. And I attended we were here yesterday, and I think that Dr. Niedermeyer, is that his name? He talked about the idea that if you look at the workforce, this was in dentistry. If you look at the workforce, look at the U.S. workforce in dentistry, that over a period of time there was an increase in the number of dentists, but the equity gap stayed the same. So why was that? I think that part of that problem was because they didn't diversify the healthcare workforce, which I think is what Dr. Lin has alluded to. You can increase the numbers. We have how many medical schools now? 144 medical schools. We have over 30 DO schools. If you can increase the numbers, but if you don't diversify that healthcare workforce or that student body, then it really doesn't have an overall impact. And so that's really our approach, and that's really kind of what we're trying to do. And this is really the mission of the center that I work in. And you can see it includes Native Hawaiians, Pacific Islanders, Hispanics, Alaskan Natives, and so on. And those are just, by federal definition, the minorities. But again, I want to reiterate the fact that we're not only looking at racial and ethnic groups, we look at people from the LGBT population. We look at people that have disabilities. We look at all people. And that really is our focus, is to bring those marginalized people into the fray, so to speak. In this talk, as I said, I'll just focus on recruitment and retention. And it's funny, the dancers that were here, I don't know the proper name for it, but the young ladies that did the dance at the end of the session, at any rate, they talked about at the University of Hawaii that they have someone that actually looks at student recruitment and retention, that is minority student recruitment and retention, which is always a good thing, and that's really where you have to start. And I think that for us, we really have to start in the kindergarten level, the K through 6 level. And it's not so much that you want to teach anybody anything. You want to expose and you want to sway the mind, so to speak. But that's where we really need to start. And I will talk a little bit about institutional climate change, which we know, I mean, you can have, for instance, you can have 20, we'll say 30% minority faculty. If that climate is not conducive to nurturing and allowing that faculty to be expressive, then it really doesn't make any difference anyway. So it's a complex issue, as we all know, but those are the kind of things that we actually look at. And this is, I'm sure you are very aware of this, but we talk about diversity within any population, and most of us talk about structural diversity, compositional diversity, and that's just numbers. I don't particularly like to talk about numbers when I'm talking to the admissions committee or the deans or whatever, because numbers are always in the news about quotas and so on, but that's what everybody looks at. They look at structural diversity. And again, if you can have a percentage of minorities within a population, but if those minorities aren't included in the decision-making process, then it probably doesn't make that much difference. But that's really what we all talk about. And we can talk about diversity of interactions. We can talk about institutional diversity. Institutional diversity just means that is your institution, is it doing what it should do to allow you to blossom as a minority? And are you offering diversity programs? Are you doing a lot of things that would help the students in particular do well? And when I think about, again, this is kind of focused on medical school. It's focused on medical school. I would love to have all 8 of those dancers that were here yesterday apply to our medical school. I mean, that would be great, and that's really part of why I'm here. Not so much to recruit, but I'm here to say that would be great, because I think in the end, if you have people from communities that have an experience with a population, then they're more apt to be able to communicate with that population. That population is more apt to be comfortable with that physician or healthcare provider, and your healthcare overall improves. So that's really the focus of things. When I think of admissions, I think of it at 3 levels. I think of it as the pre-admissions process, admissions process, and a matriculation process. And the bulk of our work is at the pre-admissions level. That is, what can we do to make a student more attractive or more competitive? And that is why we have all these pipeline programs that Dr. Lynn alluded to, is that through those programs, you can increase knowledge base, and you can certainly increase test-taking skills. And we all know that, standardized testing is the barrier for all of us. If you don't score well on a MCAT or PCAT or whatever, or the GRE, then you're liable not to be able to go to the next level. So that's what we think about when we think about pre-admissions processes. In the admissions process, that's a little bit more institutional, and there are some things that you can do within the institution. I think the thing that I will say about the admissions process, that everybody should move to what we call a holistic admissions process, and that would include race, ethnic background, and culture as part of it. And I'm sure all of you are aware that there's, just recently, the current administration released a statement that they were not going to tolerate what he's calling intentional discrimination. What that actually means is that if you, in a holistic process, if you use race as part of multiple variables that you use to admit somebody, then you're subject to be investigated or you're subject to be sued by some entity. So it would be okay to do that. So, he's trying to take it a step backwards. So we're again under the gun, and that is in the area of affirmative action, but we're under the gun as far as saying, well, you can't use race anymore. You got to use these metrics. But again, that would take several hours to talk about the admissions process. I just wanted to mention that. What I think will happen is I think that case in Texas, the University of Texas, in the Fisher case, I think it will probably go back to the Supreme Court. And then the problem is that the new Supreme Court judge, Gorsuch, he's a Trump appointee. So where do you think that leaves us? It leaves us, in a bad position, because they may overturn the current ruling that allows us to use race and ethnic background. So anyway, that's what I think about when I think about the admissions process. You can do things within the institution. You can sway people and, twist arms and do this and do that. But you kind of have to have a universal, across the board, standard, so to speak. And we're probably going to take a step backwards with that. And matriculation, that's just means the institution has to support you. They just can't bring you in and just say, well, have at it. And if you fail, that's okay. Go home. And I think for minorities in particular, I think because of our backgrounds and where we're from, I think the institution has to put things in place that would at least not so much justify, but assure in a way that that minority student moves through that process. Just for instance, I'm from Northeast Arkansas, which is rural. I went to segregated schools. I went to integrated schools. I am a son of a sharecropper. And, the dynamics in my background and my experience put me in a distinct disadvantage. And minority students still have that type of advantage when you move into the professional ranks. So the institution has to be very aware that I'm totally supportive of diversity. If I'm supportive of diversity, then I got to make sure the student stays here and gets out. So you have to put things in place to make sure that they succeed. And that's matriculation. And this, this is just a statement that I wanted to include. It's a lot of writing, but actually what this says is that this is a program at Michigan that actually looks at targeting undergraduate students, high school students, bringing them in during the summer, putting them in pipeline programs, putting them in research programs, and that's the way to approach it. And the numbers that they have and the success that they have is great. So really that's what all this writing says, is that you have to be involved as an institution in identifying, nurturing those students that you select. And now this is just a population map or table looking at Arkansas in the U.S. I think I can probably use this, can I? Yeah, I was looking at this last night, and, and actually, they don't, and I was looking at the U.S. Census also, they don't break it down into all the different races that people were talking about with Hawaiian Pacific Islanders yesterday. There are multiple races, from what I can gather. And I think someone presented some data about, I think the mental health data, and looking at how do you disaggregate that data. That's going to be hard because the population is so small, and it's going to be hard. But I'm totally for trying, but it's going to be hard. But this is how they report it. The main thing I wanted to say, if you look at just in Arkansas, which is I'm more familiar with, minorities make up about 24% of the population, and underrepresented minorities in the U.S. make up about 32% of the population. Now, the next slide, I think, talks about the number of students that actually the total population and those that actually go to, I think this is like college, and the college going rate. And this was actually in a New York Times article. And actually the population, and if you look at it, and it looks at the changing different demographics of the total population, 2012, just to make comparison, if you look at 2012, you look at the number of the white population is about 63%. 2060, it's about 43%. And, the idea is that the demographics are going to shift, and that as you go from 2012 to 2060, there will be a definite change. Now, if you look at under age 18, it's already, in 2018, the minorities will be, almost 50, whites will be 53%, and the minorities will increase in 2018. And you look at those over 65, It's about 79%. So the older people will take a little bit of a longer time to actually increase their numbers. So the basic thing is that if you look at those individuals less than 18, the minorities already have a majority or the majority in the U.S. population. And this is what this actually says here. Years when the white population becomes a minority, and that's under age 18, and actually next year that will happen. And this group, and so on and so on, at age 65 is after 2060. So again, these two slides were actually just meant to show that as the demographics change, the population that we serve as healthcare providers changes. And so we have to change who we put out there as healthcare providers. So in the end, in 2060, if you have a majority of people are minorities, then you've got to have minority healthcare workers out there taking care of people. And this is just a slide saying the same thing. 2012, 2060. And I'm gonna go ahead and skip that. This I wanted to show because, you know, it's ironic that I made this slide 25 years ago maybe. And if you look at the slide hasn't changed. The problems haven't changed in 25 years. Not since I started tinkering around with this idea of health disparities and equity and recruitment. You know, you can look at all of these areas, and you see here, this is a leaky pipeline, you can call it. And as you progress, then people drop out. And our overall aim is to get them here in health professional schools, but they drop out. And you can, if you can read, you know, those things above there, those things stay the same. You know, they don't change. They just add up and add up and add up. So these are all barriers. And I think, you know, when I think of this pipeline, I think of Dr. Samore talked a little bit yesterday about the idea of the three people in the river, which is essentially what pipeline programs are. You know, you look at, well, what happens further upstream? What happens to cause these people to be in the river? And there are all these barriers, and the things that I mentioned before, there are things that put minorities at a disadvantage, so that they never, they just go downstream and they fall out somewhere. So this is a typical pipeline presentation, and there are multiple barriers that occur. And this is, again, one of those, it's from the New York Times, and it was, I guess, like last month, this was shown. And essentially what the slide says is that if you look at 35 years ago, you look at 1980 versus now, and you look at, you know, the college going rate for blacks and Hispanics in the U.S., the gap is actually about the same or maybe even greater. And I think, you know, if, you can go and read it, but you can look at the ranges from 9 to 10%. It's about 9% for African Americans and about 10% for Hispanics. So again, our position is that we really want to look at upstream activity. We really want to look at the K through 6, in particular the high school. And so if you don't get those people out of high school, then they don't go to undergraduate school. So the gap is pretty wide, and that's kind of where we have our focus. And this is a slide that actually talks about medical school applications. Main thing you want to see here is that if you look down here, this is, I'll say American Indian. It's hard for me to read this slide, it's so small. And this is American Indian, Native American, I think, down here. The numbers are flat, and they go straight across. And there's no change, and this is from 1978 to 2014. So it's a long period of time where the number of matriculants to medical schools hasn't changed. So what do we do to change that? So that's the real question. And how do we do that? And we do that by identifying and addressing those, I guess, deficiencies within those students that would allow them to apply and matriculate through medical school. But those numbers they haven't changed. And this is at UAMS. And just to put it shortly, I wanted to show you this number here. If you look across here, this is Native Hawaiian Pacific Islanders, and you look at the enrollment, there are only 2 enrolled out of 3,147 students. So the numbers are extremely low as far as enrollment at UAMS across the board. So again, one of our deals is that we want to increase this enrollment data to the point that it at least reflects somewhat the population. I know that the population, I think he was saying it was like 0.4% of the U.S. population. You know, that's small, but still we want to increase our numbers to a point that you got to have more than 2 in 3,000. And again, what we do in the center addresses these issues. This is a lot of stuff here, but I just wanted to point out one thing. These are completion rates, and over here you can hardly see it, but there are only like 3 that completed out of this total group of 930. These are Alaska Native, American Indian, and again, it's hard. These are all people that self-identify first of all when they apply and so on. So it's hard to know, but the numbers are extremely small. The other thing is that if you look at the number of white students that complete degrees, you can see the numbers are way out here. All the other minorities are extremely low. And again, you know, the idea that we like to talk about is, well, who do you serve? What's the community that you serve? And we leave that at the heart of what we try to do. And as I said before, because the demographics will shift, and because there will become minorities will become the majority, then we have to include more people in the workforce that will serve this community. And again, we talk about social contracts that the student or the college has to make with the community. And now I'm going to spend about 5 minutes and then I'll wrap it up here. I want to talk about diversity and critical mass and what that actually means. And I wanted to present it to you because I think this is the argument that we make with admissions committees. And it's the argument that I think it's justified, and I think that it's objective. And I think as I go through these few slides, you'll see what I'm saying. When we talk about critical mass, again, we're talking about a number. It's a percentage of a mass. And a critical mass just means that there's a number within that. It's just, a critical mass is like a physics term. You know, it's a saturation term. It's a point where there is saturation and there's a change. So when you say critical mass, then we're just talking about the number within a population. The things that were shown by this particular study, and you look at, and this is looking at students and how students feel. And it looks at discrimination, incidence of discrimination on that campus. And the thing you look at is on this x-axis, you look here, this is the percent of minorities in that population. The main thing to notice is that everything goes down. And these are black and Latino students. And the percentages are 20%, 21%, and 36%. So as you increase the number of people of color in a population, the incidence of discrimination goes down. So again, this relates to the idea of climate change. And how do you change a climate that's more comfortable for minorities? And that's one of the ways to do it. So, and we show this to the admissions committee because we want to tell them that, yeah, by doing this, you make a difference, and you make a difference in the feelings of the students and faculty that are on your campus. And this again, looks at the different types of discrimination. That is verbal comments, exclusion, visual images, and so on. Again, the slant is down as you go from 20 to 36%. So this is a good objective way to convince people that diversity is a good thing and there's a tangible effect of having a diverse population. And this, I don't know, this bumped up at this level, and she made some explanation as to why this occurred. But the main thing is over here, you get this discrimination and bias drops down, verbal comments, exclusion, and so on. And this last one really looks at a feeling of isolation, which we can talk about a long time, but, you know, most students, minority students, do feel somewhat isolated. You do. You know, not all to the same degree, but there's this degree of isolation. We have diversity affairs offices, we have multicultural affairs offices, we have all these things. But, you know, still there are these issues where students do feel isolated. And isolation, feelings of isolation go away when you reach a certain mass. Now, the last few slides are just some statements about programs we have. In the pipeline programs, we have like K through 6 programs, and you know, these K through 6 programs, as I mentioned, we don't really try to teach students anything. They learn some things, but it's mostly exposure. Most students, minority students, don't really know anything about being a dental hygienist or being an X-ray technician. They know doctor, and they might know nurse, and they might know pharmacy. But we try to expose them to all these career options. So this is at the heart of what we do in our programs. We have a Pre-Health Scholars Academy, which that is really a high school program. And I think the high school component is probably one of our most important groups, because I think as you enter high school, you have to start making career decisions. And once you do that, we can help you make those career decisions and move you on the right path. So this is an important part of what we do. This is just some of the things that we do to target undergraduate students. We have a diversity day, and we have all these things, have all these students come on campus. So there are all these kinds of things. And I mentioned earlier that, you know, the idea of having a holistic process is there. And the biggest barrier to getting any student in any school is a standardized test. And we do a lot of standardized test prep. We do that for pharmacy and medicine. And that's what that summer program is about. And the last 2 programs I want to mention, the last 3 programs, we were talking yesterday about the idea of research and programs and so on. We have an R25 that actually looks at targeting minority PhD students. And I can tell you this program is about 8 or 9 years old, and we actually doubled the number of PhD students, minority PhD students at UAMS. It went from 7-point-something% to 15% just through this program. And to date, I think we've had 14 PhDs to graduate from this program. This program, I would like to see more people from Northwest Arkansas, more of the Marshallese population from Northwest Arkansas take advantage of the program, which means that we've got to get them through high school, out of high school, into undergraduate school, which we'll talk about in just a second. But this is a good program, and it helps us increase our PhD numbers. And that's important for us because, as you know, if people from different backgrounds have different interests, your research interest is probably based upon your background. You know, diabetes, obesity, and all that is prevalent in certain populations. So if you come from that population, you're more likely to do research in those areas. And the second program is like a summer research program, which we'd like to see a lot of the students from Northwest Arkansas participate in. They can come from high school, get into undergraduate school, come to the summer research program. And I firmly believe that the way to actually snag and nurture and help students progress is through summer research activities. And this is actually, we did a program in Northwest Arkansas last year. And it was a 2-day program, and we had a really good turnout. We had 42 students participate. These are all Marshallese students and 32 adults. There were 66% females. 11 high schools were represented. The grade point average you can see. And we really did all these things that you see listed here. Standardized testing, hands-on exposure, and simulated activities. So it was a good program, and of the parents, 66% of the parents were female also, and that's the household income. I think the main thing that came out of this is that we need to expand that program. We want to do a week, and we want to do more things with those students. We want to bring those students to the main medical school campus, put them in research labs, house them, and hopefully we can get them to come to medical school at UAMS. To my knowledge, there's only been in the last 10 years, one student from the Marshall Islands that applied to medical school at UAMS. So that's our goal for that. And now in the last minute, I'm just going to show you some pictures of some students. These are some students in our pre-matriculation program. And I think, part of what we want to do in these pre-matriculation programs is not only help students to acclimate and so on, but we want to expose them to the idea of health equity and health disparities, cultural competency, and biases, because that's the best time to introduce them to them. So that's what we like to do there. Now, these are little kids in our K through 6 program, and that's really the place to start for us. They're not there to learn a lot, but they're there to be exposed. And that's another picture of those students. And this is a student that's actually going to Hopkins, I think, next year. And she did summer research with us this past summer. And she, interesting enough, this is a student that was going to become a physician assistant, and now she's going to go to medical school. She decided that she didn't have what it takes to go to medical school because she made a B in organic chemistry. So, but I'm just saying, these types of encounters and these types of things, that's really where you can make a difference. And now she won't have any problems with medical school. She won't. And this is just another student that was in our summer research program. This is the group, I mentioned the summer undergraduate research program. This is a very diverse group. And we had about 70 applicants from across the country to apply to this. So it's very diverse, and they do summer research. Each year we get about 2 or 3 students from this group that apply to our medical school and come to our medical school. So it's a good group. And this is the PhD group. And I said 14 of these students have gone on and are now either doing postdocs or working in industry or doing something. So it's working. And this is the group from Northwest Arkansas. These are the high school students. And this was, again, just exposure. And we went up with some medical students, and we had a good time. And these are just pictures of them participating in simulated activities. And this probably is the best picture because the adults participated in a roundtable discussion. And as you know, if you don't get the adults involved and committed, then you might not do as well. So that was a good thing. And I think that may be close to the last picture. And I think that's it. But I do appreciate everything. I appreciate your allowing me to be here and speak. And that's it. Okay.
Thank you, Dr. Thomas. I don't know if you remember, but I met you last year, and you had me at diversity. So thank you very much. Another round of applause, please, for Dr. Thomas. It's truly a great honor to introduce our next speaker. Just a little background, I was a little bright-eyed someone, kid who attended APHA. I think it was in DC at the time. And I was doing some health education work around diabetes. And I had to use curriculums that were existing. And I had a lot of questions on, some of the methods that they were using. And of course, being new in the field, I didn't feel I had the right to kind of question some of those curriculum. Well, I've had the honor of not only running into the Pacific Diabetes Today curriculum, I was also fortunate to take the curriculum home with me. And it was the first time where I met Nia and JoAnn. So it was really a wonderful, and I believe it was truly a path. It was meant for me to go because it was a last-minute attendance. And when I saw the definition of the workshop, I said, okay, I had to go. And from that point on, it not only was a curriculum I was able to use, but it empowered me to voice my opinion on existing curriculums. We talk about standardized testing, I think we as communities also have to start to question some of these tools that are used to try to fit into our community. So it is with great honor, I'm going to read the bio. Okay, JoAnn Tsark has a master's in public health and has served as the research director of Papa Olalokahi and has spearheaded multiple federally funded programs to support programs for cancer and diabetes prevention and control in Hawaiian and Pacific Islander communities. As a founding member of Hale, she and her colleagues have mentored and supported over 50 Native Hawaiians to win and lead cancer research grant awards, developed the largest body of culturally tailored cancer education materials for Hawaiian and Pacific audiences, established the Ho'okele Ikeola Cancer Patient Navigation Training Program, and trained 212 navigators. Hale program and research incorporate community-based participatory research, yay, principles. And as JoAnn has taught me and Nia, even though researchers say they do CBPR, question, ask them what is their definition of CBPR. So I am now empowered to question that. Thank you. Let's see. Also in community leadership, capacity building, and community participation. Ladies and gentlemen, let's welcome JoAnn Tsark.
Hello, everyone. Tana doesn't realize he got to take the curriculum home because he was the only one who came to our roundtable at APHA. I want to thank Dr. Billy Thomas for his insights, and also Dr. Lin. He promised me that they have one of the biggest data sets at OMH, so we're going to take him up on that. But I just also wanted to tell you that OMH funded our first Pacific HIV/AIDS conference in Palaker, in Pohnpei, back in, I think, 1988 or something. So we're well familiar with your organization and look forward to more. Okay, where am I? So, I was driving to a board meeting early one morning out on the North Shore, and only in Hawaii you could drive by and see a hukilau going on the beach with about 100 kids. It was so fascinating. It used to be a more common thing to see, but I was so happy to see the kids out there and the adults, and they were pulling in the nets. And so this picture is not that relevant to my talk, but it is something that I really have fun memories about. So Nia asked me to share about our experiences with Hale, the Native Hawaiian Cancer Network, and to share our look through a community lens for doing this. I don't live in a academic institution. They have a lot of bells and whistles. I'm somewhat envious, but I lived in an organization where I could get a check cut in 20 hours if Hardy was in the room. So I think I was a one-up on you for that. We could move money pretty fast. And by the way, Hardy Spoor is in the room, in the back, and I just want to recognize him because big hero for me. Our executive director at Papa Olalokahi for years, but someone who trusted us to do what we needed to do. So Hale is a story about a community's response to cancer prevention and control. And it's a really small chapter in the whole health picture, but I like how Stevenson Corte yesterday talked about health sovereignty. That's exactly what was happening. We were lucky to be riding that wave of the Renaissance in Hawaiian health, Hawaiian art, Hawaiian language, Hawaiian culture back in the 70s and 80s, and health was on the tail end of that. So we had some nice champions taking down the heavy brush in front of us. But our community path is very different. It didn't follow the academic course because we were not in academia in the building. And we had to create and nurture a pipeline in our own way. So interestingly enough, most research projects and grants start with an RFA. Ours did not. It started 10 years before with a lot of conversation. As they were lobbying for the Native Hawaiian Healthcare Act, the activists that I had the privilege to know, Dr. Kekuni Blaisdell, Emmett Aluli, Claire Hughes, Nalene Andrade, these are people who are really fighting to change the health picture in Hawaii. And basically they wanted to take control and revolutionize what was happening. What was going on was not working, and nobody would say that out loud. And I think we did not have a critical mass to feel confident to voice that until we started lobbying for the Native Hawaiian Healthcare Act. And there was this whole thing, I was like, I didn't know she was Hawaiian, I didn't know he was Hawaiian, but they were pulling together and harnessing the discontent that we had, as Stevenson said, always being defined by our disease, always being defined by our weight, always being defined by our unemployment, always being defined about what we didn't have or where we were missing the mark. And for some reason, it was all our fault. Shame on us for not showing up for screening early. Ooh, shame on us for not pulling up our boots and getting the education that was out there. And that was the climate until this small revolution started to take place. We knew that there were files full of projects that were not making any difference in our community, but was using the research using the data from our community to win awards and win grants and show disparities, but it wasn't coming back home. So there was a time when I think we were going to put a moratorium on research. We were tired of just only having the role of being a guinea pig. So, you know, those 10 years, I had to remember, 10 years we discussed this, cancer in particular. And I think I got the lead because you never leave a meeting when they're discussing something because you get to be the chairman when you come back. But it's interesting that we're in this building because all of those meetings for the Native Hawaiian Healthcare Act and Papa'ololokahi and the assessments were in this building. It didn't look as nice as this. It was called the Mabel Smythe Auditorium. And it was kind of dark. It wasn't a conference center. It was offices. And I don't remember hardly if it was even a clinic, but it was our place. We had a small little office in the corner. We stole all the office supplies we needed from Department of Health and walked it across the street. And we had a center. And we talked about this for 10 years. We met anywhere and everywhere. We met at Kekuni's house. We met at Rehab Hospital. And it told me that the issue was strong enough that this conversation was going to continue to go on, and we needed to do something about it. And we were fortunate to have these activists give us charges. The charge to me was, as a young public health educator, get to the table. Go to meetings, get on boards, get to the table, bring home notes. And, you know, we didn't just go to meetings. Today I kind of feel a little spoiled. You know, we go to a conference and we come back and, you know, we had a nice time. But in those days, you know, Dr. Blaisdell would sit us down and go, and what happened? What did they share? What did you learn? And, you know, we were held very much accountable because we were struggling to get a foothold, and we knew more what we didn't want versus what we wanted. So what did we learn after talking for 10 years, right? We learned actually a lot. We learned to identify what we didn't want. We were very clear about that. We don't want to be the guinea pigs anymore. We don't want to be the last to hear about research in our community. We'd see it on the front page about how obese we were and how sick we were and diabetes and cancer, on and on. We're the last to know. And no solution. Just, oh, look how interesting this is. And we didn't want research to be made on the backs of our communities. You know, this data mining for research or taking over of intellectual property rights. Where did all this information go? And despite the fact that everyone reassured us that the data collected was public property. We were the last to get access to any of it. Never mind that we had databases at our cancer center, and we had a lot of data things. Try and get your hands on that report. So we did the stealth approach. We just made friends and would sneak out these reports. And, you know, someone said, oh, you did, Dr. Billy, you said, oh, I've had this slide for 25 years and nothing's changed. I have one that is so old it was on an overhead when I first started using it. Those of you under 25, we'll tell you what an overhead is later. But, you know, you're right, things haven't changed. But, you know, if we weren't going to change it, then who was? And we found out in a lot of these conversations that there were gaps, and we were unprepared. We didn't have a critical mass of professors or researchers that we could say, hey, let's mobilize and write a grant for this. What we realized is we had so few. We had one oncologist in the world, Dr. Chong. Hopefully he's saving a life over at Queen Emma Clinic. But he was the only Native Hawaiian oncologist. Dr. Blaisdell was a hematologist. We had Claire Hughes, a nutritionist. These were the first Native Hawaiians to get these degrees. But that was our raw material. And I'm not complaining, but these are people who came with the history of the struggle, and then I think the discontent and anger to do something about it. And I was the worker bee. The other thing we learned is we started to identify, well, if we don't like this, what do we want? And we ate a lot of poke and malasadas discussing that one, but critical to what we wanted was we wanted the locus of control to be in the community. In fact, when I was talking to Dr. Lin at breakfast, when I had his ear, I said, we got to figure out more creative ways to get money, not only going to universities, but going to where some of the real work and hard work is done. Not all of it, just to reward and to support the work that's being effective in the community. So we wanted the locus of control, and we know power follows money, which meant the money cannot bypass through the university, cannot bypass through the cancer center. It needed to sit in the community. And we also knew that one of the gaps is we weren't ready to handle a lot of that stuff. So we had to get ready, and we had to get to the table. And Hardy knows, as the director of Papa Ololokahi, that one of the real achievements was having the scholarship program. So there were scholarships that went out to prepare Hawaiian doctors, nurses, social workers, and we could get them on the side to also look at research. So part of it, we started from scratch. And the other thing is the research enterprise is brutal. You know, on a good day, professors tell me how hard it is to do research, how hard it is to win research grants. Here we were from a community group that's not historically funded by NIH, but we wanted to do our own research. We didn't want to compete to steal dollars, but we wanted to get support to answer the kinds of questions that we had put on the table, and we were ready to look at. And it was workforce development. We didn't go in looking at molecules. We went in saying, help us develop a cadre of Native Hawaiian researchers. Now, let me tell you, even though that was my passion, not everybody who wants to do research wants to do it in cancer. I didn't care, because the skill set that we were providing was to put in those values that were effective anywhere. If they ended up being a doctor, because many doctors came through to do their research, not fellowship, but their research elective, well, maybe they'd have a better appreciation for how to collect the data. Maybe they'd have a better appreciation for what they do there that feeds into the research we're doing on the other side. So yeah, the research enterprise was tough. It still is. It wasn't very friendly to community groups. We were that group that took a long time to do everything. Oh, communities take so long. You know, who is the community? Is it Auntie so-and-so in Waianae? Is it JoAnn over here? Is it Papa Ololokahi? So that told us we needed to clarify who was going to lead this charge and who we were going to train. There's also, and I use it in the present tense, a lack of understanding still for the contribution of communities to research. For some reason, this is division of labor that communities, you know, they want to be involved because they're interested, but they really have no real contribution. And I beg to differ, and I'll tell you how that has shaped and implemented and set up a legacy for what we did with Imi Hale. The other thing, this is the fun part, we were always throwing up all the disparities, all the poor thing us, and we soon learned that that cannot be the only narrative. That's not how we exist. We're not in that vacuum. We got to identify the strengths, and there were many. You know, for me to have the privilege of sitting with these champions in health who were willing to buck and really jeopardize their careers in some cases, because it wasn't popular to push the community issue back in the 80s. It really wasn't at all. So, you know, we said, well, what are our strengths? What's our inventory of things to start with, besides Dr. Chong and Claire Hughes? And we had a lot. When we put Native Hawaiian health professionals in the room, we didn't put the limit on professionally, clinically trained people. We started with students, paraprofessionals, people like me just getting out of public health school, and we had a critical mass. There are a few hundred, and we thought, we actually covered the whole gamut. And that was the raw material, and that was a lot. The other thing is, we knew that communities had needs in research, not just to answer public health problems, but they were tired of being hit up on. Can you find 100 Hawaiians to be in my study? Can you line up 100 Hawaiians so I can draw blood and take urine? No, that's not the only role they could play. The community has done my work. I've paid for it, but a lot of it was for free and in kind because they're passionate to be involved in making things better, and they did it through research that we did. The other was, I had a good champion at the University of Hawaii. Catherine Braun has been the co-PI for Imi Hale, and she was just one of those rare people, and still is, who knows the system. Have you ever tried to get a contract through your university or through your Department of Health or through your lead health agency? It's hurry up and wait, don't hold your breath. On a good day, it'll be 4 months. On a bad day, it might take 13. And that's the norm. And the funny part, being on the outside, is everybody thinks the other agency is worse. Well, they're all running neck and neck. And we don't have a monopoly in Hawaii. It seems to be the narrative everywhere. But we had a good liaison. She knew her system. She knew all of her students. So we didn't have to do the wait and will they come find us. We went out and found them. They had been students, they had been people she had been tracking, and especially in public health, many Hawaiian students went through the public health track because it was a very attractive discipline of being help and of service to your community. But that was not the only place. But she was very, and remains to be, just our greatest resource. And I know there's many of you in this room who have co-published with her, but she was another one who held the gun to our head to publish and hold up the responsibility to share that information back out. So learning the enterprise, getting on committees at the National Cancer Institute. When you don't have an institution to support your travel back in the 80s, you got to fundraise. And usually you start with your family first to get to many of these meetings. But I'll tell you where it paid off. 2 of the people I met at one of the meetings developing a nutrition brochure for minority populations became the person who wrote the RFA for Imi Hale at NCI, and he knew us. 10 years later, by the time that RFA came out, he knew who we were, he knew what we did, because we saw him, brainstorming over a brochure. The other was Dr. Linda Burhan-Stepanoff, and some of you may know her. She runs the Native American Research Center in Denver. She was having the same struggle and same issue, but she worked at NCI, but then she started her own research company for Indian country in Denver. She became a longtime mentor who we could make a call and say, what are you doing with this? Is this ethical for you? How are you dealing with this RFA? So having that kind of mentorship was so important, and we met them by being at the table over a brochure. So there's Hardy's picture. So if you don't know where he is in the back, he looks just like that. You want to talk about community-based, community-placed, and keeping the locus of control in the community. That was our Hale, that yellow building on Queen Street. It's still there. You can't miss it. And if you can't find it, it's next to the Corvette shop, which everybody knows where that is. And, I think if the termites let go of hands, Hardy, that thing would have fallen down. But it has served us well and has been welcoming, both for my project. So the gift that I had with an NCI grant was writing it through a nonprofit that was, I think I think we were like 10 years old at the time. So it wasn't a new nonprofit. And so that was it was very much an anomaly for NIH to fund a small community agency that didn't have a whole slew of epidemiologists and biostatisticians. You know, it was just, we had a lot of passion and we had a lot of drive and we had a big support group. And we got funded. You know, we worked hard. We didn't do it alone. We had made friends. Oregon Health Sciences University, I think, read every iteration of that grant daily. University of Arizona, Jenny Jo from Indian Country read through our documents. So we had a cadre of people that wanted to see us succeed and wanted to share how they were doing this. And those friendships and those partnerships have been lifelong. So we did. We had to find the resources, go after this grant. Luckily, Dr. Ken Chu wrote that RFA, and it was NCI's first effort to look at community-based research. Why? Because it was being led by Dr. Harold Freeman, who had been working in Harlem Hospital. He understood the issue of disparities. He understood that money had to start to address that, and it was not the norm for NCI. So the timing was perfect for us, just really perfect. The other thing is we didn't just chase money. I mean, there were other grants. We could have put our hat in the ring every single time, but that's not how communities engage in research or engage in training research. We went for something that was appropriate. So the 10 years helped us define what we really wanted. And the grant that came up on the table was a UO1 training grant to develop minority researchers, and it had a component for community education and awareness. It was the perfect combination for us because we couldn't just look at developing researchers when the community was in fact the driving force behind this. We had trustworthy partners by that time. We had identified what our social capital was, relationships. How many times have you filled out an evaluation form for your funding agency and they said, who's your good friends? Why not? They make our world go round and they supported what we did. This capital you cannot pay for, but is very important. The other was community interest. There's so much interest in research. And, you know, as we're fighting the telescope being built on Mauna Kea and that, you know, they keep trying to push the same issue that Hawaiians are not interested in research, and they couldn't be more wrong. You don't find a small island in the largest ocean in the Pacific by accident. So much research has gone into oceanfaring, to agriculture, to science, to medicine, diagnostics. But we didn't know a lot of that at the time. That was the pride that was being rebuilt as we were starting to push research. So we started to look at where's our social capital. And so there was a lot of community interest. There was also a lot of community fear. So I think one of the roles that were really identified for us at Papaololokahi from the communities we're working with was protect us. Protect us from the researchers. They're coming in and they're taking stuff. And I can't keep doing everything for a pencil and $10. You know, so we said, oh, let's change that dynamic and let's change that negotiation. And we had lots of champions. So this is my overhead from about 40 years ago. But, you know, sometimes you get funding, you got to be careful what you ask for, and you got to be careful what that cooperative agreement looks like, because you may end up with a swing that is not functional. And really what you wanted was some place that you could flash your hair and kick your legs up. So that was the learning curve. You talk about steep learning curve of the research enterprise and the federal government. So, you know, that was something we had to learn. We had to stop being naive about what that enterprise was and get in the game and be smart about it. Not sell your soul, but just be smart about it and negotiate. And I think Nia will tell you that there's never been a time where if we had good justification, we got approval to do something differently. We had approval to change a curriculum, the one Tana took home. So we were one of 25, initially 25 in the first 5 years, and one of 18 in the second 5 years, and then one of 23 in our last 5 years of a national network that was developing minority researchers. And I'm proud of what we did. I'm just going to go through briefly. If you were in Arkansas last year, you saw some of these slides of our accomplishments. And however good it looks, we still haven't worked hard enough. There's so much more territory to cover. But we did increase the number of Hawaiian researchers, the number of research projects with Hawaiian leadership, a Hawaiian PI, a Hawaiian co-PI. And why was that important to be outside of an institution? Because if you're not Board of Regents certified faculty, you cannot PI your own grant, even if you worked hard to win that award. So there are ways to address that with appointments, but that's something, again, the learning curve of institutions. There were lots of opportunities for research and training in many of our universities on the continent, and we took full advantage of those that were training Native Americans. We had to look for resources, but again, appropriate resources. Because I do feel like every time we get an award, I'm selling a little bit of my soul, right, Nia? Yeah. And we did increase the body of published literature. And I have to thank the Pacific Islanders in the room, because those who were running the medical officer training program and getting the doctors involved in community medicine started the Pacific Dialogue, Pacific Health Dialogue. And we bought an issue and started publishing. Where did our researchers come from? Are they all doing cancer? No. Cancer now? No. Very few. They're doing cancer related. Thank goodness we're looking broadly at chronic disease and the role of obesity, nutrition. And so we touch, and some are in the room today. These are some of the faces, but cumulatively, we probably touched about, well, that was 2015. As we've moved our pipelines to the University of Hawaii, many more have entered that pipeline as well. Also, IRBs didn't care about the research we're doing in the communities. They didn't want to be liable for anything we're doing. The one thing we had to realize is we had to start our own IRB. And because I was dumb, I thought, okay, how do I do that? I had no idea the paper burden of IRBs. But we had a community IRB for 10 years. 40% were community members. Vicky Shamba's in the room, who I'd be, Vicky, I don't understand what they want from this IRB. This is so complicated. So she would help interpret stuff, do training. We sent people to different premier trainings by Office of Human Subjects Research. But it allowed us to respond to community needs for research and have it vetted by community IRB and our community advisory board. And in the questions, I think it was easier to get through the UHIRB than our community IRB, because they didn't take 15 minutes. Sometimes they took 3 meetings. And there are lots of tiers, but if you couldn't respond to our community IRB, it was not going to move forward. We also created our own evidence for once, looking at publications from experience and research in our own communities. But guess who doesn't like to write? Me. Right? So what do? I buy an issue of the Pacific Health Dialogue, and we launch a journal. It cost us $10,000, but in that journal, 14 Native Hawaiians were first-time researchers. Took a lot of technical assistance, took a lot of help with getting those papers in shape, and I know some of you are in the audience today. And we got a lot of flack. That's not a referee journal, blah, 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 blah. I don't care. I don't care. It was our evidence. It's on PubMed now. And we moved to other journals, and another learning curve, we learned about the points journals get for being more rigorous than others. But we needed to get our information out so we could quote ourselves. We've expanded on opportunities in training and research, and as you can see from Hale and Department of Native Hawaiian Health, there are other infrastructures that have been put in place since we started Hale back in 2000. CBPR is a lot of rhetoric these days, but there's actually now institutions and programs that are actually conducting community-based research, facing some of the hard questions that Tana might ask, and now also being involved in some of the federal initiatives at the university, like the R-Matrix program and the RCMI. And it opened up for us in the community a wealth of resources and epidemiologists and biostatisticians, and people could run your numbers, because we need that too, but not at the price of losing control of what you do. There are support systems now. We expanded cancer care services. Even though we're a research organization, communities tell you we need services. We're monitoring blood pressure, we're monitoring weight, but they get cancer too. And that spawned the Cancer Patient Navigation Program. And yes, again, Dr. Harold Freeman had a project going in Harlem. That was one model. Dr. Linda Burns-Stipanoff had a project going in Denver. That was another. because I'm a health educator, it's not that I wanted to only do brochures and health education, but these are the requests that communities said, you know, that thing from the NCI or the ACS or NHLBI don't look like us. I don't eat leeks. I just don't. So you put your people out there, well, what do you eat? And which of it do we want to put in the brochure, and which one do we want to pretend we don't eat? So the thing is, we actually did, and you know, we distributed a lot and got patched together a lot of funding. Navigation is something we trained, and as we were waiting to come in today, 2 people passed us who are patient navigators at Queens going upstairs for a meeting. So tangible, give back things to the community. But there are metrics, and that's what we tell our funders, and then there are measures that matter. And I want to talk about that. Navigation is a good example because we did the formative research, asking people, do you want it? Do you need it? Would you use a navigator? All the professionals we talked to in Hawaii, and there were over 100, said, we don't know what you're doing, but if you do it, we'll help you. So for the 15 plus classes we had, for the 200 something graduates, all my faculty are the doctors that are walking around these halls, and the radiologists and the cancer survivors, and they provided over 500 hours in kind. And then some are in this room, like Gerard Akaka, and did the training for us. They had the best training. They had it from our best practitioners in the community. And guess what? When they send their patient from a neighbor island, they know their patient's going to see. And that relationship is priceless. So, philosopher said, and I love this quote, we shouldn't be defined by the smallness of our islands. And I know many of you come from very small islands, but by the greatness of our ocean. And to just finish up with this point, and yes, as Kekuni would say, we're from the biggest nation of the Pacific in the world. And yes, Taiwan is included, Dr. Liu. Yeah. But I'm going to call out Nia. And the reason I want to do this is the kind of things Nia has done so well, and we have touched her life in some parts. And you want to talk about damage control and assisting with civil defense during a disaster. Well, my contribution was keeping Nia off the streets and in our office for a good 8 years. Not to the tune of what Dr. Liu was doing, but, you know, small contribution. These are the things we tell our funders, and they're great accomplishments. But what is never said when we talk about the greatness of our oceans, and Nia I'm using as an example, because is that I never report on how much accountability she gives back to the community. Nobody ever asks me that. We never talk about, to our funders, prioritizing the community participation. When it takes 300 people to vet a brochure. Last night we had a dinner. Why? It creates relationships, and we were hungry, but it was setting up a new program. Also advocating for community concerns. Nobody said, hey, what does your community want? It's like, hey, what can you pull off? And we'll put the numeration of money for that. Also educating entities in the research enterprise. We have taken Kupuna and Pacific Islanders who have served on any of our diabetes committees. You brought senators to the table. You brought elders to the table. Why? Because they do make your world go round back at home. But those are people that got involved in research and community programming because they're an important component. So I'm not going to call you out, Nia, like I said, because you ran out of time, but mahalo. And I think we're going to be open for questions, right? Yeah.
Thank you again, everybody. If we give our presenters a round of applause, please. So at this time, do we have our speakers out in the audience? Raise your hand. Our mics out there, I mean? Okay. So this is our Q&A session. If you have questions, please raise your hands nice and high and, you know, be very energetic about it. But at this point, we'll go ahead and take some questions from the audience. Any questions? Not all at once, please. Oh, right here in the front.
all, thank you again for sharing your words. They're really insightful again. And my question is for both of you. The theme that I caught from what you shared with us is the notion that visibility and representation is really key and important. So for people who are entering into your programs, whether it's medical school or whether it's training as a patient navigator, how do you fit in traditional healing or cultural? I saw some of the materials there. How do you fit in cultural practices and traditional healing for a diaspora population of, say, islanders who were born in the U.S. but have roots in other countries or in other Pacific Islanders outside of the U.S.?
Okay. You may do better at answering the question. Yeah, I think, for a curriculum at a medical school, certainly it's hard to change things within a curriculum at a medical school or any professional school. I think what we do have, we have a curriculum in the first 2 years of medical school that actually looks at what they call alternative medicine. Now, within that, there are some parts of traditional healing and alternative medicine that are covered, but it's nowhere near, what you would even ideally think should be there if you really want to increase the knowledge base or sensitivity of a cohort of students to a particular population that utilizes that type of therapy, so to speak. So for us, curricular changes are hard to do. So we don't have a lot that I know of that specifically addresses that issue. Now, it doesn't mean that that's not something that we won't push for, because as I mentioned, I think our whole position is that we want to do the right thing, so to speak, and we want to be inclusive. And so as I go back to Arkansas, I have this idea. So if that's something that I can actually put together in a good fashion, in a doable fashion, then that's something I'll put forward. But at this point, we don't have anything that's really that targeted.
This is something that we've been wrestling with for a long time, and Hardy is one you want to tackle as you go out the door, because it's a question of liability. That's always the stumper, right? You want to protect your healers who are doing that, but this is America. Anybody can sue anybody. And there's a fear and a reality that a lot of the knowledge is gone. A lot of our traditional healers are gone, and the infrastructure to teach new ones are present, but again, people are always going to question standardized care, even in traditional healing. But I think the role for people coming into programs in medical school or nursing is your connections to where that resource is in the community. In Hawaii, it used to be families, right? The traditional healing went through families. Some communities had stronger connections. Now the healers are a little bit more mobile. They will travel to different islands, but they're still figuring out how to integrate this into everything. And I don't have answers to that, but I know it's still in demand. I know it's still being used. I know it's being expanded. I know that the Native Hawaiian doctors in particular in practice or in the medical school are always either bringing in people to talk to the students or having workshops and exposure in the community so they can take the students there. And I think that's critical to keep that open, but it needs to be elevated at some point so that, we're not always doing it as it's not an afterthought, but we're kind of doing it on the sly, or it's a workshop, it's a excursion. It shouldn't be. It has a rightful role in the medical spectrum of care, and I think we have not figured out how to do that yet. Do you disagree, Martina? Martina's at the medical school, so.
Hi, I'm Martina Kamaka, just so everyone knows, and I work at the John A. Burns School of Medicine, and I'm in the Department of Native Hawaiian Health, and we've been really looking at the impact of the interaction between culture and medicine in training our students. And for Native Hawaiians, traditional healers are critically important. I believe they're critically important in helping us to address our health disparities. So what we've done, because a lot of our students are not Native Hawaiian, obviously, is expose them to our healers. And what we try to emphasize with the students is that our patients want traditional healing, they use traditional healers, and we want them to know what the traditional healers do, give them some ideas of how they can utilize traditional healers in their treatment plans as they're working with their families. The other thing, it's really important, I think, for our teaching team to let the students know that traditional healing is a viable practice. They're getting exposed not only to the elders, but to the young ones that are coming up through the ranks as healers. And I think sometimes those are some of our most popular courses, is the ones where we actually bring the healers in and they talk about their practice, how they assess patients, and also frequently do some demonstrations to help the students understand. So I'm happy to talk to you afterwards if you have any questions.
And from a policy perspective, at Papa'ololokahi and Hardy pushed this legislation was setting up kupuna councils so that the power of, or the decision making about this were really island specific, where communities could identify who was a healer, right? You can self-ordain yourself, but then there is criteria for this. And so that islands could identify who could make the decision of identifying the healers and how that would function on their island. And that's from a policy perspective, which I think is really critical. You know?
Thank you, and I want to apologize, but our presenters will be here the rest of the day, and if you have some questions, we can continue to meet with them. But I want to be mindful also of and respectful of your time and going into break, but not going into break yet. So if we can give another round of applause to our presenters. For you, JoAnn, stay. We could just have JoAnn stay on here. We have as a Pacific Islander agenda, it's always evolving. So at this time, I would like to bring up Hardy.
Aloha, everybody. It's really with a great honor and humbleness that I come before you. We come before you as the family of the Pacific. And as JoAnn said, Dr. Lin, you are welcomed by the largest nation, the Pacific Island nation, Moana Nui Akiva, in the world. And you will find that nation is very loving and very enduring. We have a presentation we want to give to Kekumu Ola Maikai, JoAnn. JoAnn has been the navigator of the research canoe at Papa'ololokahi and the Pacific Islands for more than 20 years. Can you imagine? 20 years. And in that time, we have been fortunate to have met all of you and to have welcomed you to our Hawaii'ne, but you have welcomed us to your homes as well. And we want to just present to her a little memento of that as she moves on in her life. I can tell you there is a life in retirement. It is just as busy. And the hina on the paddle is not symbolic of the color of her hair. So with that, we'd like to thank JoAnn for all the years that she has been with us in the work that she has done for all of us in the Pacific. Mahalo, mahalo nui. Dr. Koarte has been the navigator of that waka for all these years.
Surprise. But thank you so much for, for bringing it and allow us to do all that. So there's going to be a break after this. 15 minutes, real minutes, not Pacific minutes. And during the breakout session, if you sign up or you want to be part of the best practices in engaging communities in health programs and research, your session will be here. If you sign up or want to participate in the social and environmental determinants of health, your session will be upstairs where we had breakfast. And if you sign up or want to participate in maternal child health, you will be in room 202. Again, like yesterday, we have wonderful students from the University of Hawaii. They can guide you. There are navigators. They can guide you to the right room. And then please join us here for lunch. We have a very special presentation on lectures to our students. As you can see, we have a lot of students from the University of Hawaii, and Dr. Ricklin will do the lecture because he's the ultimate professor, as we all know. And we'll be here. So enjoy, have lunch in the auditorium or outside. It's a beautiful day, so you can be there. But all our students will be required, don't maybe come look for you, required to be here to the lecture. And then right after that, we will have breakout session number 2. So you have to come to the lecture to know where you're going, or ask the folks outside. So have a wonderful lunch, and looking forward to seeing you back here again. Thank you. Thank you. No lunch. Okay. Right there. Yes.